Okay, so now let's talk about shock. You've heard us mention it before, but now we're really going to delve into it and kind of learn about it. And I believe that this is chapter 14 in your book. The first thing we need to know is, what is it? What is shock? Definition is that it is widespread perfusion to the cells, is inadequate to deliver oxygen and nutrients to support vital organs and cellular function. So in a nutshell, we are not perfusing anything, and so our organs cannot survive. Okay, imbalance in need for the oxygen that we need and the oxygen that is available. Okay, in order for us to have adequate blood flow to our tissues and cells, we've got to have three things. We've got to have a pump, and our pump is our heart. We've got to have some type of fluid, and that fluid would be our blood. And then we have to have some kind of container that holds that fluid, and that would be our blood vessels. If one of these are impaired, perfusion to your tissues is going to be compromised. So all three of those have to be in working order. Shock can develop fast or shock can develop slow. Alright, it can go in either direction. Our body is continuously trying to obtain homeostasis. Remember, I told you that on the very first day of class. So what are we going to see whenever our patient goes into shock? We're going to see hypoperfusion of the tissues. What does that mean? That just, hypo means low. So we're going to see low perfusion of our tissues. We're not able to get the nutrients in the blood, the oxygen there that we need. Hypermetabolism. What does that mean? Hypermetabolism means an increase in our normal metabolic state. Okay, so that means we have a higher need for calories because our body is using everything that it has to maintain its energy. So that's what a hypermetabolism state means. And then we also have activation of our inflammatory response. So if something's going wrong in our body, then we're going to have this inflammatory response. Again, shock is the whole body response to poor tissue oxygenation. It is a condition rather than a disease. Okay, there is some process that has caused this condition, and hopefully we're going to be able to reverse that. Hypoxia leads to multiple organ failure and death. So we want to reverse shock as soon as we possibly can. Pathophysiology. The main trigger of shock is when we have a decrease in our MAP, or our mean arterial pressure. And what exactly is our mean arterial pressure? It is our cardiac output times our peripheral resistance. So we know what cardiac output is, correct? We know that it's what our heart puts out per minute, and then our peripheral resistance, and that would just be the resistance that the blood has to go across whenever it comes out. When our MAP is decreased, it can be caused by one or a combination of any of the following things: decreased cardiac output, decreased circulating blood, or expansion of the vascular bed. Now think about those and understand if those make sense to you. Okay, our mean arterial pressure is equal to our cardiac output times our peripheral resistance. So if my cardiac output would decrease, would that make sense that I would have a decrease in my mean arterial pressure? If I have a decrease in my circulating blood volume, does that make sense that I would have a decrease in the mean arterial pressure? Because if mean arterial pressure is my cardiac output times my peripheral resistance, and I don't have volume like I used to, then that would make sense that that could decrease that. Now, expansion of the vascular bed just means that, one, in short terms, that I used to have a 1-inch hose that everything run through. Now I've got a 2-inch hose that everything runs through. So now that resistance is much less than what it was before. so you can understand how that would decrease that pressure. Okay. Our tissue and our organ perfusion are dependent upon our mean arterial pressure. We have to have a stable mean arterial pressure to get our blood to our tissues and our organs to give them the nutrients and oxygen that we need. So in short, our MAP, or our mean arterial pressure, is just the average pressure that the blood moves through our vessels or our vasculature. We need to know how to calculate our mean arterial pressure, and this is the calculation that you guys need to memorize, and that is our systolic blood pressure plus 2 times our diastolic blood pressure divided by 3. Okay, we need a mean arterial pressure of at least 65. That's what we need to make sure that our organs and our tissues are getting what they need. So go ahead and calculate these numbers here and see if you get the correct answer on your mean arterial pressure by using the above formula. You do need to know that a true MAP reading can only be calculated by it's a very complex formula or method, so to speak. So this is our abbreviated way to do it, and I do not expect you to know that complex way. I just want you to know this formula so that you're able to calculate a mean arterial pressure. So go ahead and push pause, calculate your mean arterial pressure, and then move to the next slide and see if you have the correct answer. Okay, so these are the calculations. These are the correct answers that you should have got. A mean arterial pressure for a blood pressure of 120/50 should be 73, and a mean arterial pressure of blood pressure of 90/40 should be 57. So if you used your formula, you should have got these two. Okay, so if for any reason there is a problem with our tissue or organ oxygenation, the body will compensate to restore tissue perfusion. If the problem is not resolved, then we have shock. Okay, so if there is a problem and we cannot perfuse, then our body always tries to go back to homeostasis, and if we are not able to do that, then our body goes into shock. There are 3 stages of shock that you need to know. The first one is stage 1. It is compensatory. This is, by the way, on a chart in your book, and I don't have the page offhand, so you guys can look that up. Compensatory is stage 1. At this point, our blood pressure is still pretty much within normal limits. Blood has started to be shunted from our kidneys, our skin, our GI tract, and that goes to our vital organs. And what would you consider to be your vital organs? I would consider my heart, my lungs, and my brain to be my vital organs. Your patients will actually be in respiratory alkalosis during this stage. Then the second stage is progressive. Okay, the regulation of your blood pressure can't compensate any longer, and this is whenever you'll see hypotension. It can't keep up, so it starts to drop. And your overworked heart becomes dysfunctional. This is when you will see your patient go into acidosis. Alright, so at first they start in alkalosis, but then you will see them go into acidosis. Then the third stage is irreversible, and that's whenever we have severe organ damage and it's almost impossible for your patient to survive. So we want to stop this before it gets to that severe organ damage in that third stage. And these patients are in severe, complete acidosis at this point. The earlier we can treat it, the better chance they have of survival. And research has shown if we can treat them within the first 6 hours of when the symptoms occur, that survival, patients have a much better chance of survival. This is just a resource for you guys to use, and it will help you understand the stages of shock. This is the table that it's actually on. I didn't realize that I had this in here, but you need to review this, and this will tell you the clinical findings in the stages of shock. It's very important that we ID our signs and symptoms early. Time is of the essence with this. Remember, I told you if we get to the third stage, survival is almost nil. So we want to make sure that we are watching for signs and symptoms and that we fix this quickly. Once our blood pressure starts to drop, then damage has already started occurring at the cellular level and it's affected our tissues. So we need to make sure that once we start seeing that in the second stage, that we don't let it go any further. The earlier, the better. You always want to report a blood pressure that's lower than 90 or a drop of 40 from our baseline blood pressure. Okay? If we have a drastic change, we want to make sure that the doc knows, or if we have a mean arterial pressure that's less than 65. Okay? Blood pressure is an indirect measure of our tissue hypoxia. So make sure that we're watching that. Your blood pressure is an indirect measure of tissue hypoxia. We want to monitor our pulse pressure. And what is our pulse pressure? It's systolic blood pressure minus our diastolic blood pressure. That's what will give us our pulse pressure. A normal pulse pressure is 30 to 40. Okay, so if I have a pressure that is 120 over 80, the difference in those numbers is 40. So we would consider that to be a normal pulse pressure. If we have a narrowing pulse pressure, that would be something like 90 over 70, and the difference between those two would be 20. Okay, and if we have a narrowing of that pulse pressure, it's an early sign of shock, and it is an earlier indicator than our blood pressure. So we want to make sure that we're monitoring that as well. Patients can go into shock at any point and on any unit, but really when they're in ICU, CTU, those are the floors that they're, under the closest monitoring and usually have the conditions that would put them into this. So that's being measured fairly closely. So we want to make sure that we are monitoring that. And when you read this, I told you that if you have a narrow pulse pressure, that it is earlier indicator of shock than if our blood pressure dropped. So are you thinking why? Why is that? Well, it's because if we have increased diastolic blood pressure, that means that we have vasoconstriction. Okay? And that is an early compensatory mechanism in response to a decrease in our stroke volume, okay, and our blood pressure, which in turn cardiac output. Okay, so the reason that is a earlier indicator is because if we have an increase in our diastolic blood pressure, that indicates vasoconstriction, and that is an early compensatory mechanism in response to decreased blood pressure and cardiac output. General management for shocks, the big thing is we want to support our respiratory system. We give them supplemental oxygen, and most of the time they're put on the vent. So we want to provide supplemental oxygen. That's our big first thing with this. We want to give them fluid replacement or resuscitation. Think of it as filling the tank. And when we're thinking about shock, what is the best fluid to give them? The best fluid is to give whatever you have on hand at the time, because we've got to fix this problem. So whatever is readily available. We can give them crystalloids, we can give them colloids. That table that is on there is on page 297, and that will tell you about the crystalloids or the colloids. An example of a colloid would be albumin, and that's just a large molecule solution, so it stays in the vascular space. That's the definition of a colloid, IV infusion. It's a large molecule solution, and that means that it will stay in our vascular space. The definition of crystalloid just means that it's an electrolyte solution that moves freely. between the intervascular and the interstitial. So if you don't know what intervascular and interstitial spaces are, then you need to go back and review that. Remember, we talked about the hypotonic, hypertonic, and the isotonic fluids. So make sure you understand how those fluids shift in and out of our vascular space. Examples of crystalloid would be LR, 3% normal saline, 0.9% normal saline. Those are all crystalloids. Okay. We want to make sure that while we want to give fluid replacement, that we are watching it, because if we give fluid too quickly, we can cause even more problems. Right? So we want to make sure that we're assessing for cardiovascular overload. If our patient starts to become short of breath, having difficulty breathing, they can't lay at the angle that they were originally, they may be having some pulmonary edema, so we want to go ahead and watch that, and this can actually progress into ARDS, and we talked about ARDS earlier in the semester. So we want to give fluid replacement, but there's a fine line there, so we have to keep assessing our patient and making sure that they're okay, because if we don't give it fast enough, then they could die on us, right? Because we've got to get our fluid replacement. We're not getting fast enough, we're not getting fluid in, and so we can't get tissue perfusion. But if we give it too fast, then we can overload them and cause pulmonary edema, and this can actually go into a worse respiratory situation. So there's a fine line there, and we have to really manage our patients particularly with this. Vasoactive medications that we may give, we would do that to improve our hemodynamics. Remember, we said that we want to keep our mean arterial pressure greater than 65, so we would use medications to do that if we needed to. That page 296, that table on there, will help you know the medications. You're responsible for knowing the medications and the desired action, and I've got some of them on there: the dobutamine, the dopamine, the nitro, the norepinephrine. Those are the drugs that you want to know how they work. What we're trying to do is improve our contractility and increase our cardiac output. Okay, we want to improve our contractility, we want to improve our stroke volume, and improve our cardiac output. We will be decreasing our preload and our afterload. Okay, these medications, we will decrease our preload and our afterload. This will decrease our oxygen demand. Okay, you guys remember us talking about preload and afterload and how that works, and decreases the workload on our heart. And these drugs increase our blood pressure by constriction or vasoconstriction. So you want to read that table and understand those drugs and see how each one of them will be effective in the management of shock. We'll talk about dopamine for just a second, and extravasation. We always try to give dopamine through a central line. If we don't have one, we try not to give it through a peripheral. You can, but you want to make sure that you are monitoring that IV very closely, because if dopamine infiltrates, it can cause extravasation, and extravasation is just the infusion of a vesicant fluid into the surrounding tissues, and it can cause necrosis of that tissue. That Regitine is given, and that is the antidote for it. When you are studying these drugs, make sure that you know what they do. Just as the previous slide, I was talking to you about the different drugs and what they do. Dopamine is a positive inotrope, so you need to know what inotropes are. If you don't know those definitions, you need to look at them. Inotropes are positive inotropes. They will increase our contractility, they will increase our stroke volume, and our cardiac output. So you need to know what inotrope means. Vasopressors, they'll increase your blood pressure, and vasodilators will decrease your preload, decrease your afterload, and then that will decrease the demand on the heart, the oxygen demand on your heart. So make sure that you look at that table and read about these different drugs and what to expect from them. Okay. Vasoactive medications are titrated. They are never stopped abruptly. So make sure that you titrate them. It's kind of like a rebound effect that you may have. So you never abruptly stop vasoactive medications. It can cause severe hemodynamic instability. So these drugs are titrated off. Another thing that we want to do for the management of shock is nutritional support. Okay, they require more calories than we normally do in a day, and they usually end up having enteral feedings. That's usually what the docs will order for that, because during shock our metabolic rates increase, and if our metabolic rates increase, that means that we require more energy, and therefore everything that we're taking in our body is using. So we may have to give them additional support and additional calories. Again, this is just a resource for the types of shock. Okay, and we're going to talk about those starting with the next slide. The first type of shock that we're going to talk about is the hypovolemic shock. It's the most common type that you'll see, and it is a decrease in intravascular volume by about 15 to 30%. So it shows an example there, 750 to 1500 mils of blood in a 70 kilogram person. That's what about 15 to 30% would be. So when we think about hypovolemic, what are some types of patients that would be in hypovolemic shock? It's the loss of fluid, right? Hypo meaning low. The volemic is the blood coursing through our veins. So what would cause a patient to go into hypovolemic shock? Traumatic blood loss, for one. You have someone who has in a massive car accident, okay, and they've lost a lot of blood, they can go into hypovolemic shock. Internal fluid shifts like severe dehydration can also cause hypovolemic shock. Severe edema, you have a patient who has ascites, has fluid accumulated on their abdomen. That's a big fluid shift, and that can cause the vascular space to drop and put your patient into hypovolemic shock. This is the pathophysiology of hypovolemic shock. You guys need to study this and understand how it works. It is on page 296. What happens is I have a car accident and I cut my leg and my arm and everything else, and now I've lost all this blood. So I have a decrease in my intravascular volume. So I have an event, it causes this decrease in my intravascular volume. Due to the low volume, I'm not going to have the venous return that I once had, so I have a decrease in the venous return. Because my venous return is down, I'm going to have decrease in ventricular filling. Because the filling is low, it will cause me to have a decrease in stroke volume. If my stroke volume is low, I will have a decrease in my cardiac output, because remember, my cardiac output is my stroke volume times my heart rate. And if I do not have sufficient cardiac output, then I will not have sufficient tissue perfusion. So understand this. Don't memorize a table. Understand the progression. And why would my stroke volume go down if I have decreased ventricular filling? Well, that makes sense. I understand how fluid flows through my body and back to my heart. So if one goes down, that would make sense that the other one does as well. These risk factors are 14-3. I just told you that if I had a huge car accident and I lost blood, hemorrhaging, okay, I have external and internal hemorrhage. External would be from that car accident or trauma or possibly surgery. Internal, blunt trauma, GI ulcers, or internal surgical bleeding. I could have internal surgical bleeding and not know. So all of those could cause me to hemorrhage out, okay. Also, I could have excessive diarrhea, vomiting. I could lose a lot of fluid that way, so that would be an external way to get fluids out of my body as well. Dehydration is another one. And why is dehydration? Well, it may just be because I have a decrease in fluid intake, or it could be that I've increased fluid loss. Either one of those. So those are the risk factors that you would see for hypovolemic shock. So I have it. Now what am I going to do with it? Well, first and foremost, we always want to treat our underlying cause. We want to fill our tank. We don't have any fluid, so we want to go ahead and put the fluid back in. So we've got to get some fluid back in our vessels. We will place our patient in what we call a modified Trendelenburg position, and there's a picture of it on there. And that's whenever our lower extremities are at a 20-degree angle, our knees are straight, our body is flat, and our head is slightly elevated. So you can see on the picture there that our legs go up, but the rest of us are flat. So look at that picture when you think of that. Think about if I put my patient in full Trendelenburg. If I put my patient in full Trendelenburg, what do you think could be a complication of that? First, you have to know what Trendelenburg is, right? If you don't know what Trendelenburg is, you need to look that up. Trendelenburg positioning would make it very difficult for me to breathe. So if you have me standing on my head, it's going to be a lot more difficult. We're shifting everything up, and so I'm not able to breathe the way that I need to. The second type of shock that we're going to talk about is cardiogenic shock. And what is cardiogenic shock? It's usually from a heart attack or from having an MI. It is the heart muscle is unhealthy, and the pumping action of it is directly impaired. In a nutshell, that's what cardiogenic shock is. We have decreased cardiac output, and if we have decreased cardiac output, it results in a decreased mean arterial pressure. And again, I said this in the beginning, it's the most common complication of an MI, okay? More specifically, the anterior wall MI, and that's from the LAD blockage. So remember, we've already talked about where our coronary arteries are, so you need to make sure you understand where the LAD is, and if you understand that, then it would make sense that we would have an anterior MI, okay? And so why is this? And I want you guys to look that up. You will need to see page 298, figure 14-5, and that's going to tell you the pathophysiology of it. You guys need to look that up and understand. And again, do not memorize. Understand why those things are occurring. If I have decreased contractility, that would mean I'm going to have a decrease in stroke volume and my cardiac output. My stroke volume goes down, my cardiac output will as well. If I do not have cardiac output, I'm not going to have good tissue perfusion, so it will decrease my tissue perfusion. And I will also have a decrease in my coronary artery perfusion, because if I don't have perfusion, it perfuses nothing. Okay. If I do not have perfusion to my coronary arteries, and I can't supply my heart with the oxygen that it needs, I'm going to have a decrease in my contractility, and this just cycles over and over and over. Okay? So in a nutshell, that's what cardiogenic shock is. So review that. Alright, so what am I going to do? First, we've got to treat the cause, right? We want to make sure that we treat what's going on. We need to make sure that we get oxygen to our heart, because that's what's happening, right? In cardiogenic shock, we cannot supply our heart with the oxygen that it needs. So first, we need to get oxygen to our heart. We need to do pharmacological therapy. There is a chart on page 296, and that will tell you the medications that you need to administer during this. May need to give antidysrhythmic medications, and again, there's that positive inotrope popping its head up again. So we need to know what positive inotrope is and the medications that we would give. Our purpose is to increase our contractility and decrease our afterload. That's what we want to do. We want to increase our contractility and decrease our afterload. And remember what afterload is. It's the resistance that the blood has to push against to leave the heart. We may have to do angioplasty. We may have to put stents in our patient. They may have to have a cabbage, or they may place them on a intra-aortic balloon pump, and that would help with supplying our heart with the oxygenated blood that it needs. So what drugs are we going to use to do all of these things that we want to do? We would use vasodilators. Okay, that would decrease our afterload, right? We dilate out. And our inotropes, remember I said inotropes has to do with the contractility of the heart. If you have a positive inotrope, then it will increase the contractility, and if you have a negative inotrope, it would decrease the contractility. They are given at the same time. Okay, they are given at the same time. So the vasodilators will open it up and decrease our afterload, and then the positive inotropes will increase our contraction, squeeze it out, and the resistances lead that chart to 96. I told you that we may want to put them on an intra-aortic balloon pump, and you will see that abbreviated as IABP. A lot of times that page number is 814, not 813. I think I hit the wrong number there. So you want to look at that and understand how an intra-aortic balloon pump works. And this picture down here kind of shows you that during systole it is deflated, and then during diastole the pump is inflated. And in a nutshell, what happens is that when your heart pumps out, obviously it pushes blood out into the aorta and into our body. Well, this balloon pump is placed into the aorta, and whenever it pushes the blood out, that balloon will inflate. And when it inflates, it keeps all the blood from going through the aorta, and it will backflow, so to speak. It will push a little bit of that blood back into the aorta, and when it does that, it creates a pressure that will push that good oxygenated blood into our coronary arteries, and that gets the oxygen to the heart muscle, which is what we're striving to do. So that's how an intra-aortic balloon pump works. They usually go in through the femoral. It'll be placed in there. They thread it up through your aorta. Then it has the balloon pump that's in there, and it'll inflate during diastole. And like I said, that'll increase your aortic pressure, which will increase your blood flow to your coronary arteries. And then it'll deflate just before systole, and that'll decrease the pressure in the aorta just before your ventricle contracts again. Okay, and then that will decrease the amount of resistance, and hopefully that will decrease the workload on the heart. Okay, so circulatory shock is actually broken down into 3 different types. So what could cause circulatory shock? Lots of different things. Blood vessel dilation, pooling of blood in the venous and capillary beds. It causes hypovolemia because there's not enough blood to return to the heart whenever that pooling occurs. And if that happens, then we don't have enough to push out, and so we're going to have inadequate tissue perfusion. Right? So whatever process causes that dilation out, and then this is the path that it will take from that point. This page is correct. It is page 301, figure 14-6, and that's the pathophysiology of circulatory shock. Again, don't memorize. Understand why this would occur. And what happens is you have a precipitating event, some process that causes the vasodilation. That vasodilation causes an activation in our inflammatory system, or an inflammatory response. Then we have a maldistribution of the intravascular volume. That's when we were talking about the pooling, and that we don't have enough venous return. Okay. No venous return means a decrease in our cardiac output, and no cardiac output means that we have no tissue perfusion. So that is the pathophysiology of circulatory shock. Okay, let's talk about septic shock. This is one of the types of circulatory shock. It is the most common type of circulatory shock. It is caused by widespread infection, and the most common cause of that is gram-negative. Those things can be E. coli, Klebsiella, Pseudomonas, and then we also have gram-positive for strep. But the most common infection are the gram-negative. Chart 14-4. It is on page 301 again, and that talks about the 3 different types of circulating shock. So you'll want to review that. And we're talking about all these things in this PowerPoint, but I'm giving you these references so that you have a point to go back and review. Risk factors that you're going to see with septic shock: malnutrition, immunosuppression, large open wounds, invasive procedures, any indwelling device that your patient may have, malignancy, um, chemotherapy. 30% of our patients never have an identifiable source of infection. We never know why. We can't find why they became septic, but they do. So there's a good number of that, so keep that in mind when you're taking care of them. So what do we want to do? In addition to the things that we talked about previously, as far as general management of shock, okay, we want to identify and eliminate the cause of the infection. So we're going to do cultures and see if we can try to find out what's going on. And then we'll administer the appropriate antibiotics to take care of the infection if we can find this. Neurogenic shock is the second type of circulatory shock we're going to talk about, and what that is the imbalance between sympathetic and parasympathetic. Remember, the fight or the flight. And really all it is the sympathetic is when we have vasoconstriction, and the parasympathetic is when we have vasodilation. Okay, and it's when they're fighting each other. So it's trying to constrict, it's trying to dilate, but the dilation wins out. And when the dilation wins out, we have a hypovolemic state. Okay, our blood volume is adequate in this. We didn't lose any blood, it didn't go anywhere, but we've dilated out our vessels, so the blood is just displaced. Our volume is adequate, but the blood is just displaced. The risk factors or the causes for neurogenic shock: spinal cord injury, spinal anesthesia, action of medications that we give our patients, and glucose deficiency or an insulin reaction. Those are all things that could cause your patient to go into neurogenic shock. So what are we going to do? Again, we're going to do the general management, just like we had previously talked about, of all shocks, but we want to determine and treat the cause. We want to, if it's spinal cord, we need to make sure that we stabilize the spinal cord, or make sure that we have proper positioning with our patient. We want to make sure that with anesthesia we have the head of bed at least 30 degrees, and that keeps the anesthesia from moving up the spinal cord. So we want to make sure that we have them in the proper position. The last one that we're going to talk about is anaphylactic shock. This is the third form of circulatory shock. Anaphylactic shock, you guys have probably all heard of this. It occurs fast. It is life-threatening. So we want to make sure that we get it fixed very fast. After we have contact with an allergen, it causes widespread vasodilation and capillary permeability, and that causes a fluid shift. So that's what's occurring in anaphylactic shock. We have widespread vasodilation, and it causes a fluid shift. Okay, our signs and symptoms are usually within 5 to 30 minutes of exposure to the allergen, so whatever it is. Common allergies that you'll see: eggs, peanuts, seafood, medications. Medications, a big one is antibiotics. You see a lot of patients who are allergic to antibiotics. Insects, bee stings, okay, different things like that. Those are the most common allergens that we see. This is just telling us about blood transfusions. Your patient can have an anaphylactic reaction to blood transfusions, and you guys would have already discussed this when you talked about IV therapy. It can range from mild to a blood reaction can range from mild to life-threatening. Okay, they might have facial flushing, or maybe they just have some anxiety. They may have a little bit of decrease in their blood pressure. They could have fever reaction to blood, headache, tachycardia, obviously a fever, anxiety again, or the most life-threatening is when we have hemolytic reaction. Okay, and That's whenever we see all these things that are listed on here. Blood pressure decreases, our respirations go up, and that's just whenever the blood that we put in to our patient's body doesn't like the blood that's already in there, and so we have a hemolytic reaction. It starts to lyse the red blood cells, and if we don't have functioning red blood cells, then we can't function. So it is a very serious thing if we have a hemolytic reaction. These allergens, we're going to remove the allergen. We have to try to treat our underlying cause. So we will remove whatever it is, right? If it's eggs, then we want to make sure that we keep the eggs away from our patient. We're going to give them epinephrine, and that is given IM, okay? And remember, we said with anaphylactic shock, it causes widespread vasodilation, so that epi actually causes vasoconstriction, and that's why we give the epinephrine. We give Benadryl because that reverses the effects of the histamine that is released during an anaphylactic reaction, and histamine is a potent vasodilator, so that's why we give Benadryl, because it will reverse that vasodilation that's caused by the histamine. And then you may also see drug nebulizers given, and that's due to the bronchospasms, because it's closing off our airway, we can't breathe. So you will see albuterol or other drug nebs given. If a patient has known anaphylactic shock or has a risk for it, if you're severely allergic to bees or eggs or seafood, we ask them to wear medical identification so that we know what's going on if we find them unresponsive. We want to make sure as the nurse that we identify all allergies in all patients and make sure that we document those. We want to observe our patient when administering any new medications, especially antibiotics, because you'll see that reaction pretty fast. And you want to make sure that you identify patients who are allergic to shellfish or have previous reactions to any kind of contrast dye. If they're coming in for some type of nuke med testing, a stress test, COAs, anything that we're going to put dye into their body, we need to know about that, because that can cause a serious reaction, and we don't want them to go into anaphylactic shock. So we want to make sure that we are aware of shellfish allergies that could mimic the reaction. Okay, and then just to wrap it up, the main problems with shock, what are you going to see with a patient who goes into shock? Anxiety. They can't breathe. You think you might be a little bit anxious? Pretty sure I would. Deficient fluid volume. Again, we're talking decrease in cardiac output. If I do not have cardiac output, then I cannot perfuse my organs or my tissues, and if I cannot perfuse, then other things are going to happen to my tissues. Disturbed thought process. You can't get oxygen up there, you can't think. So these are our big things that we're going to see with shock, the big problems. So we want to make sure that we try to correct them as soon as possible. And that is the shock PowerPoint.